días. Bienvenidos a ARI 2023 en este sábado 28 de octubre, luminoso en Alicante, de las instalaciones de Visum Miranza. Y vamos a hablar en este área quinta de cirugía de cristalino y lentes intraoculares. Tenemos como coordinadores de esta sesión a mis compañeros y amigos Francisco Payares y Joaquín Fernández, sentados conmigo. Y vamos a desarrollar 3 sesiones sobre técnicas en cirugía de catarata y lensectomía, sobre innovación en lentes intraoculares, el mundo de las lentes pseudotrifocales y la sesión 11 sobre pesadillas quirúrgicas. Tenemos además un panel de invitados excepcional en esta sesión que va a versar precisamente sobre la sesión 9, técnicas de cirugía de catarata y lensectomía, y vamos a conducirla en inglés, puesto que nuestros compañeros panelistas son internacionales. Welcome to ARI 2023. Thank you very much for being here today. And we're going to enjoy your presentations and indeed all the science and the applications of it that we're going to deliver. The keynote talk is about pharmacoexplication in sonulopathy by David Chang, who is the first speaker. And David, you are already with your time. Thank you very much for being here today.
This is David Chang, and I'm going to use my best teaching videos to give you some pearls for doing phaco with zonulopathy. I have no financial interest in any device that I'll show. So it's not enough to just preserve the posterior capsule in, say, cases with pseudoexfoliation. We have to worry about delayed bag IOL dislocation in the future, and that guides some of these principles. And we know the challenges with weak zonules. The pupil's often small. It's harder. Every step in the procedure is harder, including the capsulorhexis. It's hard to rotate the nucleus because the capsule isn't fixated, the bag. The zonules, being more fragile, are torn more easily, and this is important, the posterior capsule is not on tension, and so PCR is more likely with aspirating steps. So these are my 6 pearls. Don't worry about the rhexis size, but don't leave it small. Enlarge it after the IOL is there. Use capsule retractors. They are better than iris hooks. Always reinflate the bag with a dispersive OVD for either the last nuclear fragments or the cortex. Use bimanual INA if you're in trouble. Delay the CTR if possible until after the cortex is removed. And think about putting a 3-piece monofocal in the sulcus with diffuse zonulopathy. Look at the peripheral capsule here. That's your hint during the CCC that you're dealing with zonulopathy. You see the movement and the wrinkling of that posterior capsule. And I call this pseudoelasticity. It's like an elastic capsule that's hard to tear. We're using Brian Little's capsule rescue tear-out technique to finally end the capsulotomy here. Now, because of diffuse zonulopathy, you're likely with a small rhexis to end up with capsulophymosis because it's the pull of the zonules that sort of resists the contracting force of the rhexis. Think of the rhexis, a small rhexis, like a sphincter. So I suggest enlarging it. You make an oblique cut and then you tear this just like you would with the regular CCC. I like to go out to the edge of the IOL optic. And the principles are really the same. It's actually easier because you have a good view and you know exactly how large to make it. You could make little radial cuts in the rhexis if you weren't comfortable with this technique. But I find that by enlarging it, just like with any other sphincter, it sort of reduces that effect. And when you look at these eyes, even a few weeks later, you see that the anterior capsule is quiet, as opposed to being fibrotic and contracting. Again, this is especially important with pseudoexfoliation where you have diffuse zonulopathy. And these cases on the right make us realize that most capsulorhexes would keep contracting if it weren't for the opposing centrifugal pull of the zonules in all directions that keep it from doing so. So here, with PX pseudoexfoliation, I am secondarily enlarging it out to the edge of the optic. Now, there's a nasal zonular dialysis created because I aspirated the anterior capsule with the INA tip. So I thought, let's just put a CTR in because maybe it's 3 or 4 clock hours. But as you can see, It's really diffuse zonulopathy here with maybe more than 8 clock hours. And so let's see what happens now that I've put the CTR in. And you can see that the cortex is trapped, but not only that, when I pull on the cortex to your left, the entire bag is moving because the CTR is effectively transmitting those forces to all 12 clock hours of the zonules. So a CTR makes sense if the majority of zonules are healthy, but it's a detriment if the majority of zonules are poor. And now I know that the reason I caused this dialysis is because the zonules were so poor that the anterior capsule kind of was more easily aspirated by my INA tip. So what I should have done instead is use capsule retractors. These are from MST, and even though they're called the Chang modification, I have no financial interest. The tip, this is double-stranded. It's not like an iris retractor on the capsule. It's supporting it without stretching it. And they come in 4 to a pack. And these are really like artificial zonules. They are supporting the bag, fixating it to the sclera, which is what the zonules do. And so I put these in before rotating the nucleus, and they help with virtually every step. So here the bag is fixated so the nucleus can more easily rotate. That gives me support in the AP direction. It keeps the peripheral anterior capsule and fornix from being aspirated into the phaco tip. There's some restraint. But most importantly, it does not trap cortex as you saw in the previous case. A CTR doesn't do a whole lot here, and so it's more sort of a negative factor in terms of removing the cortex later on. So that's why I have not put it in here, but I will put it in later. Now, here it looks pretty easy, but I'm worried about the capsule. I put my chopper underneath it, and despite that, right there, I aspirate it. Let's see that on instant replay. So the key here is that this posterior capsule is not taut because of zonulopathy, and so it's much more likely to, oh, right there, come forward, and there is the opening that was created. So what I should have done is when you reach this point and you know you have zonulopathy, pause and fill the capsular bag with a dispersive OVD that resists aspiration. I didn't need that much OVD just to push the capsule back, but what it's doing is it's putting the posterior capsule on stretch because I don't have good zonular traction. Now, here's another situation. The posterior capsule doesn't want to separate from the cortex. It wants to travel right up to my INA tip. So you have to be super careful. And you have to recognize this is because there isn't 360 degrees of zonular stretch, and so the posterior capsule is floppy. So what's the solution? Well, don't put a CTR in. Stretch the bag instead with dispersive OVD. And it stays where you put it. It's keeping the bag unstretched. Now the cortex can more easily separate from the bag. And then when the cortex is removed, I'll attach insert my CTR and remove these. So those are two really important pearls. Now I did everything I told you about, and then in this pseudoexfoliation case with the trab, after I put the lens in, I realized the lens is jiggling. So I couldn't leave it this way, and I thought, well, let me move it into the sulcus and then suture the haptics to the iris. So to do it, you have to first bring the IOL into the anterior chamber because of the posterior angulation of the optic. It's very hard to place these haptics in the sulcus unless you're going from anterior to posterior, as I'm doing here. And I just sneak it right underneath. And then as long as I have good visualization, I can dial it in here. And this angulation of the haptics moving anterior keeps it from going into the bag. So then when I shake the eye, it doesn't move. And this is a really important teaching case because what it shows us, this is the same eye with the same three-piece lens, but there's only a difference in where it was placed. And the answer to why it's fixated better is that there must be contact between the haptic and the ciliary body, causing additional two-point fixation during eye movement. When I do this all the time now, and it's a wonderful technique. but you do want to capture the optic. It prevents the rhexis from contracting. It gives you good centration if the rhexis is centered. It also prevents rotation. For example, having the haptic later rotate through a zonular dialysis, and you don't adjust the IOL power. So here is a case of a dialysis. Now look at the bending of the CTR. It's bending there, and so I have to stop, and I'll inject a little more OVD. But when you feel that bending, do not push, because you can push it right through the posterior capsule. And this time I just sort of bend it with a Lester hook to get past that problem area of the dialysis. And I leave the retractors in place because I want to stabilize the capsular bag during the insertion. You see the Chang modification, the ends are sort of made, the tip is, that little loop is smaller so the CTR cannot accidentally go through this. I've decided that there's enough zonulopathy that I'm going to place, even though I have a CTR, I want, the CTR doesn't improve the zonules fixation, so I'm going to place the optic in the, before I place the lens in sulcus, I take out a little viscoelastic before I push the optic down for optic capture, because I don't want to trap too much viscoelastic behind there. I'll get a myopic shift. And I keep the haptic away from the zonular dialysis. Now, I think the most important strategy you have to know how to do is when you get in above your head, and I'm saying, let's see what phaco is like, and I say, wow, this is a rock-hard lens with tremendous 360 degrees of zonulopathy. Yes, should I do iris or capsule retractors? No, I don't want to take a chance. So instead, I'm going to convert to an extra cap. So I turn this into a can opener. I ignore and sort of abandon my temporal corneal incision, move superiorly, where I can have a fresh incision at the limbus. I'm not worried about astigmatism or how many stitches I need. I just want to get this nucleus out without retained lens and vitreous. So make it a generous size. I also can do manual small incision, but most people are not experts at that, so I just want to show how others would do this through a limbal incision. You can see the size of the lens. And so I have an intact posterior capsule, even though there's that zonulopathy, so I can put a foldable three-piece monofocal into the capsular bag. What's there of it, I just don't fold it in this case, but I don't have retained lens, I don't have vitreous loss, and this is a case where there you see my superior incision being closed. So in summary, these are the points that we've talked about today. Keep these in mind, and hopefully they will keep you out of trouble. Thank you very much.
Okay, thank you very much, Dr. Chang. Nuestro próximo speaker es mi buen amigo, el doctor Joaquín Fernández. Perdón, me he perdido. A ver. Así, actualización de equipos y uso de los aparatos, equilibrio entre valor y utilidad. Adelante, Joaquín.
Bueno, pues con esta presentación queríamos analizar cómo podemos tomar decisiones a la hora de actualizar nuestro equipo, tanto diagnóstico como terapéutico, y sobre todo balanceando el valor de salud que nos puede aportar, la utilidad y el coste que puede suponer. Esta es nuestra declaración de conflicto de interés este último año y que podría estar afectando a esta presentación y que debéis de ser pacientes de ella. Y hemos tomado el caso paradigmático de la cirugía Catarata asistida por láser de efecto segundo. Nos parece el mayor reto que los cirujanos segmentólogos anteriores hemos tenido en la última década entre nosotros, sin incorporarla o no. Y probablemente ese reto en algunos casos no ha sido tomado adecuadamente y queríamos transmitiros cuál debiera ser el procedimiento adecuado a la hora de hacer este tipo de incorporaciones. Y es que este procedimiento, que ya nació hace más de 10 años, con la aprobación en el 2010 por parte de la FDA. Ya sabemos cuáles son las aplicaciones que pueden tener para la cirugía de la catarata, incisiones, casotomía, fragmentación del núcleo y las incisiones acuatas. Sí que sabemos hasta el día de hoy que todo lo publicado en literatura científica, acorde a un paper, un review que recientemente ha sido publicado en 2023, que os recomiendo por el grupo de Genchi, nos viene a decir que lo reportado ha mejorado la utilidad y la precisión, pero que no encontramos realmente una evidencia clara al respecto del incremento del resultado que podemos tener con respecto a nuestros pacientes. Y claro, cuando esto hacemos una traslación de evaluación de tipo económico de este tipo de procedimientos, y ha habido dos papers claramente paradigmáticos al respecto, yo me quedaría quizás el del British College of Technology y el que se realizó en Francia a la hora de la evaluación de si incorporar esta tecnología en los sistemas públicos de salud, paper histórico publicado en Lancet. Está claro que lo que nos venía a decir es que no es solamente más caro a la hora de tomar este tipo de decisiones, de implementar este procedimiento para el hospital por el hecho del equipo en sí, sino hay que incrementar los espacios quirúrgicos, personal, también los consumibles. O sea, lleva un coste realmente importante la implementación. Pero es que además no íbamos a hacer ningún tipo de ahorro. Tenemos que seguir utilizando los viscoelásticos, el material fungible para ultrasonidos, como ya bien sabemos. Hasta tal punto que, fijaros, este paper histórico del FENCAR venía a decir que el coste de efectividad, el ratio de coste de efectividad es incremental. Por cada paciente que he operado con cirugía manual en vez de con láser de centro del segundo, llegaba a hacer de 10.700 euros. Algo realmente importante cuando se tenía el volumen global económico comparativo, ¿vale? Entonces, ¿qué oportunidad podría tener la cirugía láser de efecto segundo a día de hoy? Yo creo que lo importante es que tengamos un claro entendimiento de cuáles son los estudios de tipo económico, los diferentes tipos que podemos tener ante nosotros. Fundamentalmente son esos 5 que veis: el de coste-efectividad, que en función de las unidades que utiliza, quizás no serían tan comparables entre especialidades, porque son muy específicos de la especialidad en concreto. Cuando tenemos los mismos resultados en términos de efectividad, pues podemos irnos a estudios de coste-minimización para, si queremos comparar unas especialidades con otras, que sería lo ideal, ¿no? Decir, los profesionales que toman, sobre todo de tipo política sanitaria, decisiones de si incorporar o no, y manteniendo la línea de equidad en todo el sistema de salud, pues deben de irse a estudios de coste y utilidad en los que ya sí se usan variables psicométricas para el estilo de calidad de vida y que pueden ser comparables entre una especialidad y otra, que invertir, si en oncología o oftalmología a la hora de incorporar diferentes tipos de técnicas. Otros estudios son los de coste-beneficio. Ya si tienen en cuenta este tipo de estudios más avanzados, de coste-beneficio y coste-consecuencia, los recursos que a nivel de la sociedad, ¿no?, en los sistemas públicos, pudieran conseguir, no solamente evaluando los resultados de salud, sino pues, bueno, otro tipo de beneficios que puedan a nivel de sociedad verse incrementado o reducido a nivel global, no solamente lo relacionado con los valores de salud. Pero efectivamente, a la hora de hacer implementación de estos nuevos equipos y sobre todo comparando unas especialidades con otras, deben de ser los de coste y utilidad los más útiles a la hora de tomar decisiones. Bueno, la última actualización de la revisión Cochrane, de este preciso año, 2023, hemos tenido una actualización de la revisión sistemática en el que siguen insistiendo en que no tenemos grandes incrementos de resultados en salud cuando comparamos la cirugía estándar con la de láser de efecto segundo. Entonces, si partimos de ahí, si partimos de esa revisión sistemática, deberíamos de irnos a estudios de coste-minimización, ¿vale? Para minimización de costes, para ver si merecería la pena o no hacer esta implementación. Fijaros, este paper ha sido sumamente interesante en BMJ, publicado en el 2017, en el que, si queremos irnos directamente a este tipo de reducción de costes, nos proponían que la eficiencia productiva de producción quirúrgica debería aumentarse en un 100%, ¿vale? O que bien el interfaz de consumible de efecto segundo se recupera en un 70%, algo así como ese algoritmo que estáis viendo, ¿no?, de distribución, que un láser de efecto segundo fuera alimentando a dos quirófano para incrementar así la cirugía y que además debería de venir con una reducción del coste fungible que deberían de utilizar para que globalmente pudiera ser rentable. Pero existe un margen de oportunidad a nivel de la perspectiva económica. Bueno, en este metaanálisis con revisión sistemática nos viene a decir que probablemente lo que hemos estado estudiando en términos de efectividad quizás ha sido aplicado a nivel global y yéndonos a diferentes segmentos en concreto, como podían ser, no sé, ponían el ejemplo ellos de pacientes con disfunción corneal o mejora a la hora de hacer una recuperación más temprana. En diferentes paper proponemos el uso del manejo, el astigmatismo bajo, cuando comparamos lentes intraoculares con las incisiones acuáticas que podemos realizar con el láser de femtosegundos, yéndonos a segmentos así muy concretos o a la hora de definir estudios que pudieran analizar la sensibilidad al contraste en lentes multifocales, en la distribución en el punto focal con menor distribución lumínica, ese tipo de segmentos muy concretos, pudiéramos probablemente aventurarnos a que pudieran incrementarse esos resultados. Bueno, como resumen y en conclusión, sería que todo lo que hemos estado viendo hasta ahora, cómo aplicar la cirugía de femtosegundos a nivel poblacional y a un procedimiento muy concreto, el de la cirugía de la catarata global, claramente nos está diciendo la literatura científica que no hay un incremento de coste y utilidad manifiesto, pero probablemente tendremos que irnos no tanto a aspectos, resultados que importan a la sociedad, sino a resultados muy concretos que importan a pacientes muy concretos, casos muy determinados, donde probablemente hacer análisis de coste-efectividad en esos segmentos concretos de los que hemos hablado, sí pudiéramos encontrarnos una mejora de la efectividad y, como consecuencia, llegar a estudios que en ese balance de coste-efectividad podrían ser rentables para esos segmentos muy concretos de los que estamos hablando.
Muy bien, pues seguidamente el doctor Marc de Smet, de Países Bajos, nos va a hablar sobre la aplicación de la robótica a la cirugía de la catarata. Marc, cuando quiera.
Hello, thank you very much. It's a pleasure to be able to present to you, even though it's at a distance. And the topic that was assigned to me is about robotics and its use in cataract surgery. These are my disclosures, and there is nothing that is directly related to this particular talk at this time. My goal in the presentation is to give you an idea of where we are with automation today, where we are with robotics, what are some of the challenges, and also have a discussion maybe with you with regards to what we should be able or should accept in the future as robotics becomes available. Robotics is part of our daily lives. We use it in many different things. They will help us, for example, in tasks that are difficult to carry out, for example, in industry. We certainly use it more and more if we think about drones in warfare, as well as in disposal, for example, of mines that have been placed. And we use it in medicine for telepresence, for prosthesis, cognitive development, etc. Adoption is really the biggest issue. There are human factors, and this is also true in surgery. We have to be able to provide real solutions if we're going to use robots, and we have to take into account both the development cost for hardware and for software. Now, we are in a cultural revolution at this time with regards to technology, from which we can benefit and things will be enhanced. And of course, you've all heard about artificial intelligence, the fact that we may be able in the future to use some of our preoperative imaging in order to guide us with surgery. And this is certainly the case with anterior segment surgery. There are many promises and challenges with regards to robotics, high precision and accuracy, which is something that I've helped to develop with the Precise robot, is of particular importance. Its disadvantage, though, is that it makes movements a lot more difficult to carry out because they're magnified. Precision can be provided. We have scalable movements. We can filter, of course, tremor, but if we do so, there may be delay in response. And most of the time, I'm always being asked if we can use it for teleoperation. And that, in fact, is more difficult because it brings along delays in how the surgery can be carried out. But that obviously could be countered with time. Instrument stabilization, precision, and accuracy give us time independence. The precision and accuracy mean that we can leave something there and we can do another task. it also means that we can probably carry out surgery with much smaller openings. Now, there are robots around that are in clinical use and our attempts have been made to adapt it for ophthalmic use. And this is, for example, the Da Vinci robot. And yes, experimentally, you can show that you can carry out a penetrating keratoplasty. You could carry out part of a cataract surgery and even bring in an intraocular lens. But the machine itself is extremely bulky. The precision of the tasks that are carried out are not so precise. You can see how there's a lot of movement going on here while we're simulating a rhexis. And so there are certain limits. Da Vinci was made and created ergonomically to do abdominal surgery or prostate surgery, but it is really less adequate for eye surgery. In eye surgery, we need definitely ergonomy that is adapted for a small area with restricted access, and we need to be able to use reference points or remote center of motions. It has to be safe, both in terms of ocular movement as well as patient movements. And as I've already mentioned earlier, robotics is only useful if we provide real solutions, and these would include, for example, enhancement on things we can do today. Now, of course, robotics for you in the cataract world and in the refractive world is already here, since all of the refractive procedures that we do, we punch in numbers and a laser carries out surgery. So in many ways, it is already there. The two main systems at present that have been discussed about with regards to ocular robotics are the IRIS system, which is a fully roboticized system. The surgeon essentially uses his two hands using some instruments to guide the surgery that is carried out at a distance, usually next to the physician himself. It uses what is called an RCM, or remote center of motion, along the point of entry inside the eye. This particular system also has a built-in OCT camera, and by the use of this combination, they're able to complete lens removal in experimental settings in about over 80% of cases, or it's either complete or nearly complete. There's very limited incision stress that is being placed on the incision itself, level 1, as you can see here, so it's really quite mild. Essentially, it means that there is a mild opening of the incision. It doesn't compromise even the sealing. With regards to iris damage, it's also very limited, usually to only a contact or a single damage point. And the time of surgery is in fact relatively acceptable if you think about duration. And this is with a system that hasn't yet been fully developed at this stage. The precise system essentially is a micromanipulator that is being used when you need it. It's at the operative side of the eye that is being operated, so on the right or the left. The surgeon has a joystick, which you can see in C down to the right, that brings up this blue device that is being positioned inside the eye to carry out surgery. So far, it has only been developed really for vitreoretinal surgery, but could be adapted for cataract surgery. And there is a publication out now looking at its potential use in glaucoma. It doesn't occupy much space. The surgeon is still at the head of the patient and would use the system when it's really required. It has high precision accuracy. This is very important for us because we need both to have high accuracy. That is to say that we're always at the right spot, and we want high precision, which means that we always come to the same spot. And if we let the robot work on its own, it has a precision accuracy of 2 microns or less. As you can see here, I've used here the Z because this is the most difficult in penetration. It is definitely better than if we're going to do it using a manual control by a surgeon, and also both in dynamic and static states. We can show here, in fact, that with static positioning tasks, there is very little motion using the robot. It's in fact well under 5 microns, while on the right-hand side, manually, we have 100 microns or more with spikes that go up to 250. And this has to do with the fact that we're in fact animals made to move, and if we try to stay still, we'll have micro jerks that will go to at least 250 or 300 microns every so often. And if you want to make steps in depth, for example, deeper into a cataract or deeper into a capsular bag, you can do so with high precision in steps of 5, 10, 50, or 200 microns, as was done here, with absolutely no motion. So as a surgeon, robotics provides you different types of functions: motion stop, assisted positioning, task suspension, as I've mentioned earlier, which translates for the physician in less strain, a restful position, less stress, and it allows you to start considering new solutions. In other words, you could get into, for example, the capsular bag with absolutely no motion and be able to carry out something in this space, something that manually would be hard to do. We've done some simulations using the IC simulator and looked at the potential for retinal injuries in people that were non-trained. And you can see that manually you end up touching the retina, causing hemorrhages in a number of cases, while it doesn't happen with a robot. And yet in this case, the limit was placed under the level of the retina by 50 microns. This simulates subretinal delivery. You can see the instrument position in Z. We have two test surgeons. Above, it's done manually, robotically below. The one on the left is an experienced surgeon. He does very well. You'll notice that on the left-hand side, there's a hell of a lot of tremor in somebody who has no experience doing subretinal delivery. But if we look in the turquoise lower panel, and also with regards to positioning in pink, in fact, using the robot, the inexperienced surgeon does better because he leaves the robot to do the surgery and the experienced surgeon tries to take over. The interesting point is also to look at the figure up to the right with time. We instructed people to try and keep in the simulated subretinal space for 30 seconds, which they did manually. When they used the robot, the average was much higher because now the time constraints and the stress associated with it was gone. It's been used clinically. This is macular peel done in Zurich. You'll notice that there's a trend to feel that using the robotic system gets easier over time. Physician 1, 5, and 8 were in fact the same, so he had more difficulty adapting. The other physician did a lot better. This is another study done in Rotterdam where you can see that over time, less and less time is required for surgery as the whole team, surgeon and nurses, gain experience, and the surgeon himself travels a lot less inside the eye, which is a measure of the reduction of the risk of having a problem. What if we were able to use, for example, a laminar flow system and bring it outside of the OR? We could start thinking about office-based robotic surgery, and this may become a necessity as the reimbursements for this become less. And if we have a simple setup that we can use in the OR, that would be great. It will bring new competencies that need to be achieved. That is, are we able to use a robot on our own? When are we able to teach individuals to use it? In many ways, I think we can use the models that have been used for aviation. And what level of automation should we want? Well, that will depend on how good the machines are and our ability to control. I think it will evolve in the direction of what has happened in aviation is we'll always be there to control what happens, but we will with time leave it more and more over to a robotic system. Thank you very much.
Thank you very much, Mark. El siguiente speaker es Robert Osher, de Estados Unidos, con manejo de la cápsula anterior en casos comprometidos. Adelante, Robert.
When it comes to complications in cataract surgery, the posterior capsule has always received top billing. But complications involving the anterior capsule are every bit as important and require the same knowledge and discipline to manage. For example, compromised visualization of the capsular edge can be due to a mature brunescent cataract. The capsular rhexis is lost, and so is the surgeon, until he removes the OVD to allow the injection of trypan blue. The errant edge is identified, and the capsular rhexis can be completed. Compromised visualization may also be caused by a white cortical opacity, so the surgeon should not plan to finish the manual rhexis over a white spoke. Again, the capsula rhexis is rescued using trypan blue. Suboptimal pupillary dilatation or constriction due to IFUS can also cause poor visualization of the capsula rhexis edge. So, you guessed it, we resort to the dye as a rescue maneuver. But this is different. There is a dreaded notch. It's necessary to denotch the capsular edge by excising the discontinuity. Otherwise, the surgeon is risking a peripheral extension later in the procedure. A break in the capsular rhexis margin can be very subtle, yet ignoring or missing this defect could turn a routine case into a nightmare, so the notch is excised. Trypan blue would improve visualization, but is there a downside to trypan blue? Absolutely. Doctors Ehud Asiya from Israel and Burkhard Dick from Germany have separately identified the increased brittleness of the capsule. Trypan blue is injected, and when the INA tip simply touches the anterior capsule, it breaks. Reminds me of the first time I saw the anterior capsules disintegrate in cases of aniridia. We investigated a piece of the aniridic anterior capsule and discovered that it measured an average of only 6 microns rather than the usual thickness of 14 to 21 microns. This is analogous to the thin posterior capsule associated with the posterior polar cataract. Oops, sorry, we are not allowed to talk about the posterior capsule in this video. Based on a spectroscopic study conducted by Dr. Minu Mathan from India, elasticity of the anterior capsule can be retained when diluted trypan blue is used if the dye in the anterior chamber is promptly washed out. The intumescent white cataract has its own risk profile. The culprit is not the trypan blue, but rather the increased endolenticular pressure that produces the Argentinian flag sign. This is vintage footage of the original complication described by patriotic Argentinian surgeons, Drs. Daniel Perrone and Roberto Albertazzi. Brazilian surgeon Dr. Carlos Figueiredo explained that a relative nuclear block separates the lens into 2 compartments, each with a separate elevated pressure. It is important to pressurize the anterior chamber with a retentive OVD like Healon 5, which flattens the lens bow. A small capsular rhexis is made. The nuclear block is broken by ballotting the nucleus backwards, which Dr. Figueiredo called posterior voiding, which decompresses the posterior cortical compartment. Now, the case becomes routine, and with intraocular scissors and forceps, the rhexis can be safely enlarged. If one follows these recommendations, the Argentinian flag can be confined to Latin America. Rarely, the anterior capsule will require urgent attention. This elderly patient became disoriented and tried to abruptly leave the operating room during the capsular rhexis. Only the quick reflexes of the scrub nurse who hurled her body across the patient's chest prevented severe bodily harm, while the anesthesiologist was delivering sedation to both me and the patient. Following the injection of trypan blue, the capsular rhexis edge was recovered, proving Dr. Charlie Kelman's favorite saying, "It's better to be lucky than good." Cataract surgery can be humbling, especially when we encounter the unexpected. The capsular rhexis, phaco, and INA are uneventful. Do I see a little cortical strand in the peripheral bag? Is the enemy of good better? Did the anterior capsule just split? Can I pretend it didn't happen? Thankfully, renowned pathologist Dr. David Apple taught us that the anterior zonules have ample strength to arrest a peripheral tear. If we're careful, a toric lens can be safely implanted. The OVD is removed first from behind the lens and then from the anterior chamber. The toric lens is aligned with the thermodots, and all is well. As Dr. Kelman preached, it's better to be lucky than good. But sometimes our luck, like the capsule, runs out. Notice how the torsional phaco-tip is rotated so the bevel is vertical, which hits the anterior capsule, causing an instant split. The nucleus was carefully emulsified, and the cortex was ever so gently removed without taking a single breath. The confident surgeon used the autonomy injector to deliver the Clarion lens, but the haptic opened backwards, launching the tear around the equator and through the posterior capsule. Time to be both lucky and good. The IOL was maneuvered into the capsular bag with the haptics well supported by peripheral capsule, and vitreous was undisturbed. Charlie Kelman must have been watching over me. The anterior capsule is like the 11th commandment. Thou shalt treat me with respect. Knowledgeable management of complications involving the anterior capsule will result in a lovely eye, a satisfied surgeon, and a happy patient.
Muy bien, bueno, pues en el manejo de lente lusada y sublusada, la técnica de Yamane probablemente una de las más reconocidas a nivel mundial. ARI ha conseguido que el propio autor, Shin Yamane de Japón, nos describa la técnica en la próxima presentación.
Hello everyone, thank you for inviting me. My talk is about management of dislocated IOLs with the Yamane technique. For managing the dislocated IOLs, we have two ways. The first choice way is an refixation of dislocated IOL. In this case, I refix the dropped IOL with the Yamane technique, but I usually remove the dislocated IOL because the haptics of the IOL is deformed if the IOL was fixed in the back. In this case, the IOL was an sulcus fixation, on the back fixation, so I confirm the haptic is not deformed. And this IOL is have a rigid optic, so I don't want to enlarge the scleral tunnel. So I perform the refixation, repositioning of the dislocated IOL. In usual, I remove the dislocated IOL and fix a new lens. If the dislocated IOL is rigid one, I make 6 or 6.5 millimeters from incision. And normally the dislocated IOL is foldable lens, so I cut the IOL and remove it. I love to use this technique, cartridge pull-through technique. This is very easy and fast, so I usually use this technique for removal of dislocated IOL. After removal of dislocated IOL, I use the Yamane technique for IOL fixation. I start the surgery without pupil dilation, and I first inject dispersive OVD in the anterior chamber, then make PI with vitrector. After that, I perform subtenon anesthesia, and this anesthesia induces pupil dilation. After vitrectomy and removal of dislocated IOL, 30 single needles are bended 45 degrees with bevel up, and 2 square tunnels were made with the needles. The insertion angle of the needle is very important. It must be symmetrical. So I usually use a needle stabilizer, and the IOL was inserted on the iris. This is very important point. The main wound for IOL insertion should be separated about 70 or 80 degrees from the left square tunnel. Then the haptics were inserted into the needles. I always grasp 2 or 3 millimeters from the tip of the haptic. Then align the haptic with needle before insertion. Then insert about half of the haptic into the needle. This is the same technique. Grasp 2 millimeters from the tip, then align haptic with needle and insert the haptic into the needle. Then the haptics were externalized with the needles. I usually cut the haptic 1 or 2 millimeters because I usually use a large IOL with 7 millimeters optic. If I use a normal 6 millimeter IOL, I don't cut the haptic. Before making flange, we must dry up the haptic, and the flange must be fixed completely inside the sclera. If the flange is too large, or if you don't fix the flange completely inside the sclera, it can move after surgery, and subconjunctival flange lead the conjunctival erosion. So again, we must fix the flange completely into the sclera. If the flange is too large to insert into the sclera tunnel, you should enlarge the entry site of the sclera tunnel. After that, you can fix the flange into the sclera tunnel. You should fix the flange like this OCT image. And for practice of this technique, I recommend you to use a model eye like this similar eye for Yamane technique. It's very difficult to use porcine eye because the diameter of the cornea is too large. Yamane technique is very simple and minimally invasive way. Positional relationships of the wounds, grasping point of the haptics, and the insertion angle of the needles are important for successful surgery. Thank you for your attention.
Thank you very much, Dr. Yamane, and we have now time for the debate. In the debate, we have very distinguished panel with Dr. Mendicute, Isabel Prieto, Filomena Ribeiro, and Juan Álvarez de Toledo. Thank you very much for being here today. And we are going to conduct this debate in English, as far as Dr. Yamane is here as well, and Dr. Smith. So let me make the first question to Dr. Yamane. A great technique, and which is your favorite intraocular lens? Because not all lenses are that good for this technique that you have created, right? So my question is, which are the lenses that you prefer? And please tell the brand names even, just for us to know which are your preferences.
So I love to use an 3-piece IOL with a PVDF haptic, like a Core, Avanci, or Zeiss City Lucier, because PVDF is very flexible and easy to manipulate. If you use PMMA haptic, it has a risk of break or deformed during surgery.
And do you have complications like late extrusions of the flank haptic, ones that is remaining underneath the conjunctiva? Is this a frequent complication in your hands?
Sorry?
The extrusion of the flank haptics, whether it is frequent or not in your hands. Well, do you have experience in the Yamane technique, Javier Mendicute? Do you use it?
Yeah, not so much, but I have practiced that technique, and it's very friendly. But it's true that after the operation of the technique described by Canabrava, I prefer to use Canabrava technique with ProLens and with different models of intraocular lenses. But Yamane, I think that it's perfect in order to reposition one intraocular lens if the lens has 3 pieces. In other cases, I think that the best option could be to manage the complication with other techniques.
Isabel, which is your favorite technique for lenses that have to be fixed to the sclera, as far as you don't have capsular support?
You're on mute, Isabel.
Isabel, we cannot hear you.
You hear now? It's better now? Okay.
Yes.
It's my, you are asking me that reposition of IOL?
Yes, which is your favorite technique for scleral fixation?
Scleral fixation is kind of a technique. I like it so much. I tried some with the Yamane techniques. It's very friendly. I use a couple of cases, but I think it's better another with a kind of a technique. I think so better. I like more.
Yeah, and Filomena, which is your favorite technique for scleral fixation? Something that is frequently a problem.
Yeah, I think as you mentioned, the extrusion and the possibility of having an endophthalmitis is a problem that we need to face with this type of scleral fixation. So both techniques, the Canabrava and the Yamane for sure, they are very good techniques. The question is always to bear the final bulb in order to not have this extrusion and the risk of endophthalmitis.
Very good. I think Joaquin had a question for Martin Smith about robotic surgery.
Yes, I really think that it would be a very interesting approach to this type of surgery. What do you think are the real challenges to apply in the clinical practice?
Well, I think, the cataract surgery is probably where robotics would make a lot of sense for standard cases. What you've seen in many of the presentations now are complications. And so there it would be hard to necessarily use robotics. We're essentially been trained to use our hands to do surgery. So I think for complicated cases, that will still be the case for quite a while. Where I think robotics will come in its own era is when, surgeons like the people here on the panel and others will start to use the robot to do things that we're not able to do today. So, for example, do we need to do a capsulotomy? If we had a stable entry into a lens, maybe we don't need to do a capsulotomy. And obviously surgery, even for cataract surgery, has evolved over many years. So the initial steps, I think, are going to be things such as doing a good rhexis, similar to what was done with femtolaser. And from there, we're going to evolve to more and more complex things that robots can do. So they'll help us with the premium area in cataract surgery, and progressively we'll move down to the more common types of surgeries we do for cataracts, and then evolve into the complicated case, such as the pseudoexfoliations and others.
We had a very interesting presentation with Osher, putting attention on the anterior capsule and anterior capsulotomy. Making the capsulotomy with femtosecond laser, we have in some cases breaches, some tears in the anterior capsule. Do you have any tips or tricks about that, how to reduce? Somebody told about to reduce the pressure of the cone. You try to reduce the fold in the endothelium to reduce the breaches. Do you have another tip or tricks about energy or whatever?
I think it depends on how you're approaching the technique. There was an old technique that also, at least if we're talking about robotics, the approach it could use would be to use a form of electrical dipoles, which, without putting any pressure anywhere, can go around the surface of the capsule and make a very perfect capsulotomy. So no pressure is placed on it, and you get a perfect circle. The system isn't really being used anymore, but it is a very efficient one, and avoids all kinds of pressure, traction, or anything that is being generated inside the eye. We don't need it in normal surgery, but with a robot, it certainly would be a very nice added tool.
Mark, one question that I have for you is the robotic surgery that I have seen in other specialties usually takes longer time than human surgery. In other words, an experienced surgeon is faster and very efficient, while the robotic takes a significant more time, even that is precise as well. And I'm talking about abdominal surgery, not eye surgery. So do you expect that robotic surgery, when developed, will be like this, will be taking longer time than a human surgeon surgery?
So if we look at what has been done so far with posterior pole, with retina, precision tasks take more time. And at present, the draping and everything takes too much time. That can be solved. If I think just of retinal surgery, there are some steps that we do slowly because we don't know where we are. That can be accelerated. But the very precision task, we won't be able to do, I think. But if you start thinking about changing the way we do cataract surgery, I'm sure that you're aware, years ago, aqualace was used or tried. It didn't work very well, in part because we move around too much inside the eye. But if we could find an optimal way to be able to remove the lens without moving that much, with maybe even more energy because we now have a full capsule, then maybe we can save time. We won't save time doing what we do today. We'll save time if we start using the precision, accuracy, and the stability of the robot to look at it in a different way. But precision work takes time, whatever we do. We have to save steps somewhere else.
I do think like that. My opinion, robotic surgery will be different than the surgery we are doing today. It will not reproduce our surgical performance. It will be a different type of surgery with different tools and different ways to evacuate the nucleus, probably with a femtosecond that will really liquefy the nucleus. It's going to be different. Cannot be performed like it is today, clearly, in my opinion. Well, Juan, you are there. probably in Córdoba, as far as I see, probably the most behind. Well, what do you think about that? Because you use femtosecond as well. Do you think that really we are in a moment in which we are going to move into different techniques in order to simplify the surgery, to make it more straightforward, and then is the place for robots? What do you think? We cannot hear you. Juan, we cannot hear you.
Yeah, now I think you can. I've been practicing cataract surgery for the past 30 years, and it has changed a lot. And I think in the future, it will change a lot. As you mentioned, really, it's going to be a completely different surgery. I think people of our generation, we are not trained for PlayStation and other things. And young people will perform a different way. As you mentioned, we will have lasers that will liquefy the crystalline. We'll have a robot that will create automatically a well-centered capsular exit. You can put a device inside the eye and the robot will aspirate the lens. So it's going to be much, much different. And I hope so. It will benefit our patients.
Okay, I think that we have the time over. Any other question, Joaquin or Paco?
No, not really. Perhaps for Juan, we have seen in the presentation of Robert Usher that he has a cut in the anterior capsule. He doesn't perform any other discharge in the opposite side of the anterior capsule. Do you usually do that to prevent a decentration of the lens?
I think it's a good idea.
What?
I think it's a good idea.
Yeah.
Well,
if you cannot rescue the notch.
Yeah. I think that we're over the time. So I want to thank all the speakers. It was a fantastic session with very nice videos and very instructive surgery. And a look to the future with the robotic surgery will be, in my opinion, something that is coming in the future, but long time from now. So thank you very much. The session is closed, and I appreciate that you had the time and the willingness to be with us today. Thank you very much.